So today we will discuss some points about as PONV. What are the factors and how to deal with and avoid the incidence of post-operative nausea vomiting. Okay. So any one of you face this PONV, post-operative nausea vomiting?
Yes, sir. Sometimes in the recovery area, when the patient is held in the post-operative period immediately after the surgery, or 20 to 30 minutes after the surgery, it is a common happening that usually happen in the OR.
Hmm. Okay, so what is your experience? In which patients you will have more of this problem? Yes, who was talking? Is it Yasin or is it Abhi? Who was speaking out at the moment? If we just, first of all, if you can just think, what will be the problems if patient is vomiting? In the post-operative period, if patient is vomiting, what can be the problems?
Aspiration, then prolonged hospital stay, increased cost of the treatment, and I think so.
What about surgical? Is there any effect of vomiting on the surgical side?
Yes, it will increase the abdominal pressure and maybe wound hit.
I'm sorry, I mute you by mistake. Can you unmute yourself, Yasin? Yes, please.
Maybe it will cause wound hit.
Okay. Okay, so this is one thing. Then what about electrolyte imbalance? Or if it is too much dehydration? What else? If there is aspiration, this will create respiratory distress and everything. Prolonged hospital stay, prolonged discharge from PECU. Okay, so it will all increase the morbidity, you can say. Okay, morbidity, and also, of course, if there will be prolonged hospital stay, there will be more chances of delayed in ambulation. Okay, so delayed in ambulation, so there will be more chances of venous thromboembolism. Okay, so these things are interlinked. So it's not only vomiting. There are so many things which are which will be the sequelae if the patient is having vomiting or nausea. Okay, so this is one more thing that anything would you like to see when the patient vomits in post-operative period?
Sir, any aspirate or bloody content, or if the gut surgery or the laparoscopic cholecystectomy is performed, then any sort of sir, gastric material or biliary secretions.
Just a second. You are directly going towards aspiration. Okay, so the thing is that, practically speaking, if you are extubating the patient in a situation that patient has aspirated, it is actually a disaster. Okay, so actually this is not the first thing to think. Is there anything related to vomiting, nausea and vomiting which you should rule out whenever you have? Of course it can, there are so many factors for vomiting. So, but would you like to rule out something else? It's a very simple answer. Would you like to see something else when the patient is having vomiting or nausea?
Sir, hypotension.
Very good. Okay, So first of all, your approach should be airway, breathing, circulation, and hypotension is the thing you should rule out. Okay, because maybe this is a sign that patient is not hemodynamically stable. So this is the important point. Whenever, this is actually not for exam point of view only, this is a practical advice, that whenever there is patient is nauseated or patient is vomiting, even if you are giving spinal, if you have given spinal, this may be a sign that patient is about to have a dangerous reading of blood pressure. Okay, so whenever there is nausea, vomiting, think in multi-direction thing, and the most important thing will be this one. Okay, yes, of course, again, airway, breathing, circulation, you should be considering everything. Okay, so another thing is that we will just try to go into the details. What are the factors? So generally these are the things which are effects of post-operative nausea, vomiting. We have chalked out. There may be some other, but generally it is. So now if we just think about the factors which will lead to post-operative nausea, vomiting factors. Okay, so first of all, to start with, what will be the anesthetic factors which can lead to post-operative nausea, vomiting?
Sir, in anesthesia-related factors include the inhalational agents,
Inhalational agents,
opiates,
opiates,
and use of nitrous oxide,
nitrous oxide, very good, and
Answer duration of anesthesia.
duration of anesthesia, I don't think so.
So prolonged NPO.
Prolonged NPO. Prolonged NPO, and in now after surgery, we will not say it as prolonged NPO. Dehydration. Okay, if you have given less fluid, then there are more chances of patient having post-operative nausea, vomiting. What else?
Opioids, drugs.
GA versus spinal. GA will have more incidence. If spinal can have, but so for some other reason. Okay, but GA medications will have more. General anesthesia will have more effect. What else, Sumera? Anything else?
If the patient is diabetic, I think because of delayed of gastric empty, maybe get them in risk of post-operative nausea and vomiting.
Yes, but actually, remember one thing. The people a number of time mix aspiration and post-operative nausea, vomiting. There is some relationship, but actually they are separate things. Okay, so yes, you are right. Not only diabetic, CRF, pain, emergency, surgery,
and sir, gastric dilatation due to back mass ventilation.
gastroparesis. Okay, yes, of course, actually these are the factors which are interlinked between post-operative nausea, vomiting and aspiration. Okay, so actually these are the things which we will quote more related to aspiration. Okay, yes, of course there will be more incidents, but if you just think about anesthetic factors, if you think about any other anesthetic factor, what about hypoxia? Is it any link with hypoxia? Okay. So what about now if you go to these are actually patient factors. So among the patient factor, what is the most important factor?
Sir, previous history of PONV and history of motion sickness.
Female. The female gender. Okay. Female gender is a risk factor for post-operative nausea, vomiting. Okay. What about
type of obese patients?
I'm sorry.
Type of surgery.
Dr. Humera, just concentrate on my question. We have not reached up to surgery. We are talking about patient factor.
The non-smoker.
Non-smoker, okay. one thing, non-smoker.
Extreme of ages.
Is it more chances in elderly patient? Because children have. What about elderly?
Old age.
Is it more? Are there more chances?
Sir, children have twice risk of PNV than for adults.
Okay. So, anything else?
Patients with high intraocular or intracranial pressure.
Okay. Intraocular pressure
Sir,
also.
history of intestinal obstruction and hypoxia
Okay.
and gastroparesis,
Mm,
obesity,
Patients on drugs.
which drugs?
Sir, opioids and tranquilizers, antidepressants.
No, please. Antidepressant has no relation with, and again, I'm telling you that some factors are related to aspiration, not post-operative nausea vomiting. Okay. So there is a little bit difference between post-operative PONV and aspiration. I know that of course, if patient will vomit, it can aspirate, but we are concentrating specifically on post-operative. Among the medication, have you missed one very important? I was expecting Sumaira, at least you should tell. Neostigmine. Okay.
yes, sir.
Neostigmine is one of the one of the culprit for post-operative nausea vomiting. Okay. What about in induction agent? You can just divide, think any analgesic agents, these are opioids. Inhalational agents, you are using nitrous oxide. And among the induction agent, which can cause more vomiting than other?
Etomidate and ketamine.
Okay, so propofol has the least incident, and rather it is anti-emetic effect, while ketamine and etomidate can be. Okay, and okay,
As a prolonged PONV can also cause prolonged NPO
yes, we have
can also
discussed.
cause PONV.
We mentioned about it. Okay, so now surgical factors. So
Okay.
which surgeries will have more chances?
Strabismus surgery, middle ear surgery.
Sir, laparoscopic surgery, intra-abdominal surgery,
Anything where vagus nerve is
intracranial
involved.
surgeries, and
Wherever
middle.
vagus involvement is the main, one of the major factor. Okay, so whether it is
Okay.
strabismus surgery, whether it is this one middle ear surgery, whether it is abdominal surgery, okay, laparoscopic surgery. So wherever there will be some stimulation of vagus nerve, there will be more chances. Okay, so okay, but I forgot to mention before, at that time I was, is hypoxia a cause of more this one PONV?
Yes, sir. Hypoxia also causes PONV.
Okay, okay. So actually these are the things which you should be knowing. And
Dilatation.
I'm sorry.
Sir, dilatation of uh, this anal canal may
So
cause vomiting
cervical
or
dilatation.
cervix.
So I told you these are all vagus related. Okay, so these are all are vagus related. Okay, so okay, so now if you just go towards the medication, how to manage it. So if you want to avoid it, you should avoid the medications. Avoidance is a better, you should avoidance of medications. This is one thing. Then good hydration status. Okay, wherever multimodal analgesia, okay, wherever possible use of this one local wherever regional anesthesia is possible, okay, and use of multimodal analgesia. Why I have written multimodal analgesia? Because whenever we will be using multimodal analgesia, the opioid consumption will reduce automatically. Okay. So if, for example, if you are using dexmedetomidine or you are using lidocaine, okay, along with other medication, you are using paracetamol, you are using NSAIDs, okay. So if you are using a combination, you have given the local infiltration or some block. So what will happen? The requirement of opioid will reduce. So automatically chances of post-operative nausea vomiting will reduce. Okay. What else? Now, if you go to medication, so how will you? What medication group you can use?
So we can use anticholinergic
Anticholinergic.
and antihistamine.
5-HT3 receptor.
These days, what is the first line?
Antihistamine.
What is the first line?
That is 5-HT receptor antagonist.
Okay. Have you heard of? I forgot the mechanism of action. What about aprepitant? This is a new medication which I think it was related to substance P, if I'm not wrong. Just correct me.
Yes, sir, it's related to substance P.
Okay. So more of the risk factors, you will be using combination. Less risk factors, you can use one of them. Okay. So the first line you told anticholinergic and antihistaminic. Unfortunately, these are not in first line. Okay. First line are steroid, and there is one medication which is very effective for not only delirium, it is also effective for nausea feeling. What is that medication?
Haloperidol.
Haloperidol. Okay. So haloperidol mechanism of action is?
Sir, it is dopamine antagonist.
Okay, so it is dopamine antagonist. So you have to be careful while using it in patient with Parkinson's disease.
Parkinson's disease.
Parkinson's disease. Okay. So dexamethasone you will give, and these medications, a very famous medication which is written in every book you have not told.
Onsetron, ondansetron.
No. Metoclopramide. And there are so many studies which say that it is not more than a placebo effect. Okay. And the dose at which it will have a better anti-emetic effect, at that dose extrapyramidal symptoms can occur. Sumaira, what will be the treatment of extrapyramidal symptoms?
Antihistaminic, sir.
Yes, diphenhydramine or diphenhydramine. Okay.
Sir, metoclopramide, it does have effect on active vomiting, but it does not have any prophylactic use. Am I right?
No. You are telling the
PUN.
other way around. Dexamethasone is for prophylaxis.
No, sir. Metoclopramide. I'm talking about
Metoclopramide.
metoclopramide.
Yes. Actually, metoclopramide is used. What is the mechanism of action of metoclopramide?
So it improves the gastric motility.
So it has effect on dopamine receptors, both peripheral and in the CTG. Okay. So
Yes,
the central effect is anti-emetic actually, but for central effect you need more dose. So actually it is just helping in enhancing the gastric motility. Okay.
Yes, sir.
So some of the common side effects of both haloperidol as well as ondansetron is QT interval prolongation. Okay, so it prolong QT. So you should be considering, and of course about this one Parkinson's disease. Okay, so like overall, because every in this regard, the best management is prevention. Okay, and if you are using propofol, you are using dexmedetomidine, you are reducing the opioids in use. So actually, the chances of post-operative nausea, vomiting will be reduced. Okay, so just we will just have a look. So
So
antidopaminergics
there
and
are some criteria to see
more risk and
the
less.
incidence of post.
This one aprepitant is NK1 receptor antagonist. I didn't remember it, so I was saying substance P. I'm not sure about, because I have never used it. It's not available even in Saudi Arabia. It's an American drug, because you will not find its name in British books. You will only find this aprepitant in American books. Okay. Usually.
Then this metoclopramide, are we supposed, because sometimes we give it on table, maybe some like 10 minutes to the procedure. And
Okay.
yeah, its action, its onset of action is, I don't know, its onset of action. So does it work if we give it like on table, or maybe some few minutes after the procedure?
Yes, actually, you need some time. As I'm telling you that metoclopramide, there are so many studies that its effect is not more than placebo. So if you want to have its effect, you need to give it in higher dose. And at that higher dose, actually side effects come. Okay. So metoclopramide is not a very good medication if you are considering use as antiemetic. Okay. Uh, it is actually like just use in a combination for aspiration prophylaxis. Actually, they are using this H2 receptor antagonists, or proton pump inhibitors, or either of them, or an metoclopramide. And in addition to that, if you want to neutralize the pH, you have to add the this non-particular antacid. Okay, so actually it's a so this is just some like involvement of vestibular system, and this is area postrema, chemoreceptor trigger zone, subgastrointestinal signals. Okay, so this is just a emotional stress, because in this article it was also written that anxiety is also one of the factors which will result in this one more chances of PONV. Okay, so that's why preoperative anxiety relief is that so important. Okay, they can ask you in MCQ about the this one the pathway. Okay, so it's written here: ejection phase, muscular activity. There are more chances of, and actually the problem related to the, it will also affect on the surgical site, especially if it is abdominal surgery. Okay, the striated and smooth muscle activity is coordinated by the autonomic visceral efferents of cranial nerve 5, 7, 9, 10, 11, as well as spinal nerve to the abdominal muscles. Okay, so these are few words about it was written here, and because I just chose the topic from this book. Inshallah, tomorrow we will do aspiration.
So have we
Sumera,
discussed?
yes.
So have we discussed about the criterias for seeing the incidence, the POVOC score and Apfel score?
No, you can just share if you remember.
Yes, sir. The Apfel score, it's used in adults, and the POVOC score is in children.
Okay.
In Apfel score, there are 5 things to be seen, 5 factors. One is female gender, one is history of PONV or motion sickness, third is non-smoker, fourth is post-operative use of opioids. Sorry, the five. And the incidence is like there is 0 factor, 10% risk, 1 factor, 20% risk, 2 factors, 43 factors, 60, and 4 factors, 80% risk.
Yes, actually, we have
The
just
folks,
discussed these points, but without this name. Okay,
yes, sir.
without this name. But of course, I think I just saw this because it was not written in previous book. This criteria name was not written. It was just even in this link which I shared. There is documents which my friend actually pulled it out. So we have just discussed some of the factors, but of course they can ask you the criteria name as well. Okay, so dehydration, alkalosis, electrolyte imbalance. So these are the things which we have already. So you go keep a good hydration, minimum fasting, and that's why also in the part of this IRAS protocol, the same thing. Okay, or etomidate, opioids, hypotension, hypovolemia. Okay, avoid inflating the stomach with gas, avoid tracheal intubation if possible. Okay, and use of volatile agents, ensure adequate hydration, minimize visceral traction or distension, which will stimulate this one vagus. Okay, avoid neostigmine, use either cisatracurium or rocuronium, which you can reverse with the Sugamedex. It will reduce the chances. Okay, and propofol, TCI, not necessarily, remember one thing, if someone is reading this book and just try to reproduce this word, you can tell them, but it is better you just say that if you are using propofol, there will be less chances of PUNV, especially if you are using an infusion. Okay, because if you don't know what is TCI and you name this word in front of the examiner can catch you. Target control infusion, you know about target control infusion. Okay. Okay. Any other point? Sumaira, are you still here? Anything, Sumaira, about
Yes, sir.
post-operative nausea, vomiting? Anything you want to add?
Sir, like strategy for reducing the PUNV, like how to give one drug and a combination of drugs in which patients.
Yes, that's what Zishan was just telling shortly. Okay. So there is a criteria.
Alright.
You will just count the risk factors. Okay. You will say that if you are giving too much opioids, female gender, surgery involving vagus nerve, there will be more chances. So
No, sir, like strategies for reducing the PUNV.
no, yeah, that's what I'm telling you. That if you have more risk factors, you will have more, like you will have to use a combination. You will avoid
Right.
dehydration. You will avoid prolonged fasting. You will give multimodal analgesia. That's what I just written shortly. Okay, you will
Okay,
use.
sir.
I have I have shared these criteria, these scores in the group, sir.
Okay, just a second. I hope the WhatsApp is on. No, it's not working. Anyways, so I think we have covered a number of points about it. So inshallah, tomorrow we will just try to discuss the remaining part, the aspiration. Okay. So tomorrow we will, because actually, the number of factors are correlated. So inshallah, we will do the remaining part. I think PONB, this is a very important topic. They can ask you practically, even for the juniors, if you are this is a practical tip as well, that try to avoid dehydration. And majority, my message to all of you, majority of our patients, actually, unfortunately, we are not giving proper fluid. Okay, we are afraid of fluid overload. I ask any one of you, how many times you have faced a normal young patient going in fluid overload by you? Yes, Sumaira, Zishan, anyone? Dr. Munawar?
Very rare, sir.
Very rare.
So
Okay?
no one like.
I have never in 18 years of my career, I have never overloaded a patient. Okay. So the thing is that though Yes. So unfortunately, because we are afraid, oh my God, we will overload the patient. We are denying the patient. Okay. The patient is not passing urine or even passing urine very dark, and we are worried. Oh my God, we will not give fluid because patient will go in, and it will never happen. Even if, for example, if you see that you have given a lot and patient has not passed the urine, or you see you have something which is called as furusemide. Okay, you can use it and you can remove the rest of the fluid if you have any doubt. But actually, unfortunately, we are giving very less fluid. So don't be afraid. You know, if a surgeon is afraid of bleeding, or if an anesthetist is afraid of overload and hypotension, he unfortunately, how can he play? दाग नहीं तो सीखना नहीं. Okay, if you will not take a chance, you will not learn. You will actually, you cannot manage the patient if you are afraid. Okay, so I hope that's enough for this topic. And actually, if the people who are not following this discussions, I started this. I started this book, and we are covering some topics from that book. Okay, so you can find the earlier topic being discussed in the playlist. Okay. So, yes, you know, at least 15 to 20 minutes, Dr. KG. Yes, I hope you understand. It will take some time for its effect. Okay. Okay, so thank you very much. Inshallah, we will have the same time, inshallah, tomorrow. Thank you.